Hello and welcome to the EMS On Air podcast. The mission of this podcast is to keep healthcare providers safe, informed, and prepared. Today is March 5, 2021. I'm Jeff Lassers and I'll be your host. This episode was recorded on February 22, 2021. Even though we are located in Southeast Michigan and we mention our home state a lot, today's content applies to EMS on the national and even the global scale. This is a 4-part series focusing on EMS patient care reports, or PCRs. This series has been developed in collaboration with the Oakland County Medical Control Authority, or OCMCA, and various EMS providers as a way of providing information and guidance to EMS agencies and personnel. Although we reference the OCMCA and our local and state EMS protocols, this series is beneficial to all EMS agencies and providers. Like most EMS systems, the Oakland County Med Control focuses on quality assurance and/or quality improvement programs with a patient-centered approach. To facilitate this process, the OCMCA develops and disseminates required education to its EMS providers as one aspect of their annual EMS Quality Improvement Program, or EQIP. Since 2015, EQIP has provided a uniform, standardized, systematic, and responsible quality improvement program through education and OCMCA support. EQIP can be broken down into 3 primary components that all OCMCA EMS agencies are responsible. These include required data reporting, required education, and measurement of protocol knowledge through assessments. In 2021, all OCMCA EMS agencies are responsible for assuring that all of their EMS providers complete this 4-part series or cover the same learning objectives with their personnel. All of the details regarding the 2021 EQIP requirements can be found at ocmca.org/EQIP. EQIP. That's ocmca.org/EQIP. Again, even though this series was developed specifically for EMS providers in Oakland County, Michigan, it certainly applies to EMS on the national and even the global scale. It is impossible to cover every detail, aspect, and nuance of an EMS patient care report. However, we hope that EMS providers and agencies use this podcast series as a way to start a conversation and/or train on producing quality PCRs that consistently show an understanding of current protocol knowledge as well as patient-centered decision-making in the field. Throughout this series, you'll hear from a core group with a vast amount of experience and knowledge. Everyone that appears in this podcast series has significant experience with EMS education, QA/QI programs, as well as EMS agency and system administration. Joining us in today's discussion, we're lucky enough to have Emily Bergquist from the State of Michigan EMS office. Emily is the State of Michigan MCA coordinator, as well as a longtime paramedic and EMS instructor coordinator. We're also lucky to have Emily Baker, who is the current EMS coordinator at Ascension Providence Hospital in Southfield, Michigan. Emily is also a longtime paramedic and instructor coordinator who also occupies the position as the CQI supervisor for Alliance Mobile Health, which is a private EMS agency in Oakland County, Michigan. All of our guest contact information can be found in the episode description. In this episode, we'll discuss EMS patient care report narratives. Primarily, our goal is to increase EMS's appreciation and awareness that the narrative reconciles the entire patient care record, as well as how to implement best practices into their work. To accomplish this goal, our guests are going to help us list and describe the use of various EMS narrative writing methods, including SOAP, CHART, the chronological method, and DRAT. Then, we'll list and describe the minimum information that should be included in the narrative of every EMS transport of a patient, as well as the additional information required for an EMS transport of a patient with a time-sensitive emergency. Then we'll finish off the discussion by listing and describing the minimum information that should be included in every patient care narrative for every patient care refusal, as well as what must be included in every patient care narrative for every EMS patient pronounced on scene. Please keep emailing your questions, comments, feedback, and episode ideas to the EMS On Air podcast team by email at qi@ocmca.org. Also, check out our website, emsonair.com, for the latest information, podcast episodes, and other details. Follow us on Instagram at EMS On Air. And please, whatever podcast platform you use, subscribe to the podcast and leave us a rating and a review because it really helps us to grow this podcast. I really can't ask you guys this enough. Please leave us a rating and a review and help us get noticed on a much larger scale. Remember, the mission of the EMS On Air podcast is to keep healthcare providers safe, informed, and prepared. So, increasing our ratings and our reviews gets us noticed by more listeners and more sponsors that will lead to increasing our reach, resources, experts, and abilities. Bottom line, ratings and reviews are currency in 2021. It is vital to our growth, and your contribution will give us what we need to serve those that serve our communities. The only cost to you is a few minutes giving us a rating and a review on whatever podcast platform you use. We're available on every podcast platform that you can think of, so it's super quick and easy. Thank you, and enjoy the podcast. Good afternoon, ladies. How are you?
Pretty good. Happy Monday.
Doing excellent. Thank you.
Well, happy Monday. Thank you for being here for our last installment of our 4-part series about EMS documentation. Today, we're going to kick things off by talking about these various EMS writing methods that are out there. There's a number of EMS writing methods that are taught in initial education and by agencies throughout the whole world, not just Michigan, not just the United States. Now, there's no clear best method, but let's go over the most commonly used methods that are being taught. Most importantly, let's highlight the primary goal of each of these methods, which is really to be the legacy of that EMS call and all of the downstream effects. So, Emily Berquist, why don't you kick us off? Tell us about SOAP.
SOAP is an acronym for Subjective, Objective, Assessment, and Plan. And this one is one of the acronyms that's kind of been adopted from other areas of healthcare, and EMS kind of co-opted it. Subjective meaning things that you feel or see around the patient, things that are describable but not necessarily measurable. So then objective meaning the measurable things that you found, so pertinent negatives, any sort of interesting vital signs, etc. Assessment being the things that you found and what you did as far as assessment, like you did a physical assessment, you did a very specific assessment of the chest, etc. And then what plan, your treatment, and things like that goes inside the plan. So that's SOAP.
Now, that method seems to be almost too simple for me when I look at this. But when we really break it down for new providers, I find that's the easiest way to start the conversation. And it seems to be one of the first ones that we teach because it really breaks down the call, like you said, the subjective stuff. What happened that isn't a measurable thing? Objectively, what did occur and what did I do and what happened to that patient? What are the assessment findings throughout the entire call? And what was our plan and how we kind of executed it? But then there's another one, chart, which gets in a little bit more detail. I always find that's the second one taught to people as they matriculate through the process of learning EMS charts. Can you walk us through chart?
Sure. Chart is complaint, history, assessment, RX or treatment, and transport. So chart kind of breaks the SOAP method a little bit further. So complaint, obviously patient's chief complaint, any history that you found, again with the assessment, the prescription, RX, or treatment, those are the things that you did, and then the transport, what happened when you're transporting the patient. So by adding that extra, kind of breaking it out a little bit further, it becomes more EMS specific. So what you did and then what happened during transport. I think that kind of dovetailing on what you said, Jeff, is that these are kind of our building blocks for creating a good narrative. So if you're a new provider or you're not somebody who writes very often, these are good ways to kind of break your stuff up into chunks so that it's understandable to other people.
I totally agree. And what I find myself is after I looked at these for a number of years, and I've been in EMS for, 18, 19, a bunch of years now. And now I pretty much use the chronological method, we all call it, right? I got called to this and I tell you the story to the end because I've done it so many other times with so many different methods that I just kind of know all of the key points and I put them together in a chronological story. And I think over the last, decade or so, the EMS industry has recognized that the chronological method seems to be the easiest for our 5, 10, 15-year providers that move on through the system to be the easiest one for them. But to give that an objective acronym like SOAP or chart, there's this new one to assist us with completing a chronological narrative called DRAT. Emily Baker, why don't you walk us through DRAT?
As you said, DRAT is basically a defined breakdown of that chronological format. It starts with your dispatch information, then your response, arrival, assessment, treatment, and transport. One very important thing that this format highlights is that your call does begin when you're dispatched. Your response to the call is relevant because delays are relevant, and it just pushes you to include that information. This acronym was developed by the National Academy of Ambulance Compliance, And they actually teach a class on ambulance documentation that focuses a lot on compliance and legalities. And they stress this significantly, and it is very useful.
It certainly seems that way. I've always had a problem really teaching the chronological method to new EMS providers in a way that was like in that checklist method that really helps them learn. And I like that DRAT now exists because it really breaks down what I do all the time. I didn't know I was doing it. And I think that's why it exists. So again, dispatch information, what were you sent to, what happened on the way there, what did you find when you arrived, what was your assessment of that patient, what did you do for him, and what happened during transport. Now, there's obviously way more detail in it, but that does certainly lend itself to a little bit more detail than SOAP and chart. When we talk about actually putting these things into play, it really doesn't matter which method you use. What's most important is to include key information in every narrative. Now, for an EMS transport of a patient, this will include a number of things. Now, in this section, let's go over each item that should be included in an EMS patient transport narrative and discuss the role and importance of each item, as well as provide some examples. Emily Berquist, why don't you start us off on the list?
Well, the first one's the easiest one. It's the age and gender of the patient. We know that some of this information in the narrative is also in the other sections of the PCR, but because the narrative is a place where people go to learn the story of the patient and the big picture of what's happening, sometimes it's important to make sure there's redundancy in that narrative. So one is age and gender. That can be really simple, and sometimes it's a little bit more complex, but it is a good place to describe anything that might be not able to be captured earlier in the report. Then after that being the brief description of the scene, including factors pertinent to the patient condition. So for example, if it's a patient who's having an asthma attack and they're surrounded by 24 cats, important pertinent information that you can't put somewhere else. Yes.
Yeah, or maybe, it's this time of year. Right now, we're recording this in February in Michigan, and we've had a snowstorm for the last week. So if it took you an extra 5 minutes to actually get the equipment into the structure to access the patient, that's the type of information that should go there. But in most times, routinely, it's arrived to find 65-year-old male patient called to because of, and it's really that simple.
Right, exactly.
I think it's very important to highlight this portion that you need to do a brief description of where and how your patient was found. Your narrative should not be able to apply to a vastly different scene. So, for example, if you're writing a cardiac arrest call, I should not be able to read that narrative and apply it to a patient that died of natural causes and a patient that has a knife sticking out of their chest.
Makes sense. Yeah, so how you found that and presented that patient. And really, a lot of times that ties to our next thing, which is the reason for the call, why they're there, right? Which a lot of times kind of goes back to that brief description of the scene, including factors of the patient's condition.
Yeah, and the reason for the call, it can be really specific, like we were called because the patient's having an allergic reaction to a bee sting, or it can be something that involves a lot more description. We're in coronavirus right now. The patient was diagnosed with coronavirus last week. They've had increasing difficulty breathing. And then today they were unable to take 2 steps without difficulty breathing. And that's what prompted the call. So I think the key point to this is like, what is different about this moment for someone, say, who's chronically ill that prompted the 911 call?
Agreed. And then really it's important to say, what's your impression of this person? I got here and now what is it I'm presented with?
For example, if we read a report and we're like, oh, that patient wasn't so sick, then you find out the patient died, it makes you feel like somebody missed something. This is a place where your general impression, that person looks really sick. Make sure that you specifically describe why you think the patient looks really sick. The patient is in significant respiratory distress with tripoding and obvious retractions versus the patient is speaking in full sentences and not having any obvious outward respiratory distress. Those are important things that help tell the story of your patient.
Yeah, and sometimes it's as simple as I arrived to find that 65-year-old female patient in no obvious distress, speaking clearly and telling me that her foot hurts or whatever it is. You can kind of summarize it all, but you're hitting these points of, it says right here, they found a person that's not in any distress, essentially. It's important to say, what is it you found? And we're not talking about writing a big book here. Okay, so you look at this patient, you identify your impression of them. At this point, what's wrong with you? What's important about documenting the patient complaint?
A patient complaining of something is representative of the patient's ability to complain about something. So if the patient is telling you one thing and they're feeling something different, or they are presenting a different way, that's important. It tells part of the story about reliability and the patient's condition. If the patient's unresponsive and they cannot complain of anything, that's also important about the entire situation. So the patient's perspective does matter. It does say, okay, the patient is complaining of respiratory distress, but we're finding them ashy and pale and other things that seem unrelated to a respiratory distress. Those things are all part of an entire picture that we're painting.
So after they make that complaint, it's also important to then move on to the next thing, which is their presentation of signs and symptoms. So what are they complaining about? What are you actually seeing? And based on that patient's experiences?
Goes back to what we just were saying, is the patient's complaining of respiratory distress, how it's presenting. So they've had an increased productive cough, they have exertional dyspnea, the other things that are associated with that particular chief complaint. So it's like the patient is complaining of and presents with these other things that are associated with that patient complaint. I can say the patient is complaining of respiratory distress. Well, respiratory distress is a lot of things. It can be a cough, it can be exertional dyspnea, it can be profound respiratory distress where they can't even move or talk. There's a lot of ways that can look. So make sure that you're including all of those things as part of the description of the complaint.
And then from there, I think the next best thing to do is additional assessment findings of what is there and also the pertinent negatives, what's not there. For instance, you have a patient with chest pain, it's important to identify that they may or may not be having difficulty breathing. If somebody's having crushing chest pain, it's like, no, my breathing feels fine. I just have this crushing chest pain. That is a very important, pertinent negative because usually that type of chest pain is associated with difficulty breathing or nausea or vomiting. And it's important to list what is and isn't there because that is additional information. It is just as important.
This is also where it would be very important to list any discrepancies between what the patient is stating and what you are finding.
Right. If there's a mismatch between the complaint and your findings, because patients may be confused, they may be withholding information, they may be in a situation where they're not conveying it in a way that they're not capable of giving you that information. And that's also important to kind of tie together at this point. Also included in your narrative, another big key point is your interventions and treatment, and including reasons for protocol deviations or why you didn't do a treatment. For instance, if you didn't give
aspirin. That's my favorite one. That's the easiest one to say why you did or didn't do.
I go to a chest pain. Prior to my arrival, the patient took on their own 324 milligrams of aspirin. I'm going to withhold that aspirin, but in my narrative, I'm going to put the patient took aspirin on their own, and I don't need to give it to them.
Right, or they took one baby aspirin, so you're giving them 3 more. So you're doing a dose deviation. Any one of those things are important to note in the narrative because that's different than what would usually happen. Maybe they're allergic to something, or they had some sort of adverse reaction, or the patient refused a treatment, or whatever. If you didn't do something that you think probably should have been done or would have been done in a different circumstance, that's when you should also note that.
This is also where you have room to provide further description of that situation. So, for example, if there is a religious or cultural reason that a patient is not comfortable with something, then document that.
Or if they just don't want it.
Because that happens sometimes too.
Yeah, I had an old lady the other day said, I just don't want the IV. She was stable. She didn't want the IV. I didn't fight her. We weren't going that far. She didn't get the IV. I put in my narrative. This patient denied me administering an IV. No problem. When I do any intervention or treatment, it's very important that I document the response to that treatment, even if there was no change. It kind of kicks back to the interventions I come on to say here is we list all of the interventions in a flow chart. We describe them in our narrative. Now you can easily say administered IV as charted or administered morphine for pain management as charted. But then you got to talk about what happened to the patient after. How did they respond to that? Did you give glucose and nothing happened? Well, that's very important that you write down that in the narrative.
If you have an adverse outcome, for example, not maybe adverse outcome's not a good choice of words, some sort of strange side effect profile, or even some side effect that's kind of an expected one. For example, you gave adenosine. you better describe exactly what happened when you gave adenosine, because there's going to be a change or there's not going to be a change, and it's important to note what that is. I gave adenosine, there was a pause, but they went back into it, or there wasn't a pause, or I gave adenosine and the pause and they converted. In the flow chart pieces, it doesn't really allow you to give that kind of description. You can improved, worsened, etc., but you don't really get a good picture of what exactly that means. So that's important to make sure you're being specific about what the change was.
So throughout the patient care, I'm doing a lot of things to this person. I'm with them during their event. Time is passing by. It's important that I'm always keeping eyes on this patient and remeasuring what's going on. So we have a reassessment or ongoing information about this patient or change. So Emily Berquist, can you kind of tell me why it's important to really adequately describe how or if my patient has changed?
We've talked about this in a previous episode, I think, a little bit about stability and what the definition of stability of a patient is. I'm pretty sure Emily Baker talked about it in a different one, but stability is the lack of change in a patient. And so if you say my patient was stable and I didn't need to intervene, you should be able to back that up with something which involves more than one set of anything. So if you're kind of trying to prove the value of the treatment that you're getting and the assessment that you're doing, it needs to be almost continuous. I know in school they teach you, 5 minutes for really sick patients and 15 for stable patients. But when you're in the back of an ambulance, you're in about 12 square feet of room with you and another human. You should be paying attention to them at all points in time, and you should be noting anything that's changing. So maybe the patient's pain is something that is pretty subjective for people to measure. So the patient's pain scale didn't change, right? They said it's still an 8, but we noticed that their pulse rate went down and the patient appeared more relaxed. That's important pieces about your assessment that goes to show that something was changing, even if the patient hadn't really quantified it with a number change yet.
I think that it's very important to note that those visual observations of your patient, that they appeared more calm or their skin signs improved, GCS can be observed. So just because you aren't doing a complete full set of vital signs with a blood pressure and a pulse ox, et cetera, it doesn't mean that you aren't reassessing your patient, and you need to document that.
I concur. And now, a lot of times, that reassessment or ongoing information really precedes the transport summary. I took the patient to the hospital. I'm oversimplifying this, but I transported the patient to the hospital, no change in status. What information should be included in that transport summary?
So this is where you talk about like the change in position of a patient. So the patient was uncomfortable in this position, and so we sat him up, or, there's all sorts of different things that can go in the transportation. You got stuck by a train, for example. There was a train crossing and you had to stay there for a while, and so you spent a lot of extra time. Whatever happened inside there, the patient was extremely uncomfortable because the roads were really bumpy. All of those things will help in the long run in getting a good story of what happened when it was just you and that other person in the back of the ambulance.
Now, sometimes in the back of the ambulance, I might need a little bit of help, and I can call online medical control to get a little bit of assistance. Or there's a million other reasons I could call for online medical control. And every time I do, it should be documented in the narrative.
Well, I think that one reason is because you need to make sure that you're noting, even if you're not asking for orders, there's always, I shouldn't say always, a lot of places there's still a communication that occurs. We notified the hospital that we were coming, so they knew we were going to show up. And I know that varies from facility to facility. But also, if you're doing something, a post-radio intervention, or you're asking for a protocol deviation, etc., that relationship that you've established with the person that you're talking to is important. So you need to know who it was that you talked to. So if you're getting an order from a physician, you need to know who that physician is. You can't just say, well, I'm not sure who I talked to. When you come into the hospital and you say you did something and they say, well, who told you that was okay? You can't just shrug your shoulders. And people should know after the fact. So make sure you're noting who you talked to and what you talked to them about.
The recordings of those contacts can also serve as additional documentation if anything is questioned or if there are any concerns regarding the transport and or transfer of care.
Emily just made me think of something. This is becoming more important over time. Make sure that you're using an appropriate method of communication and noting what that method was. Are you talking on an unmonitored line, like the HEAR radio? Because some people still do use that. Did you talk on the 800 radio? Did you call on a phone? And if you are calling on a phone, make sure that you're doing it on a recorded line. So those are just like, make sure you're noting if you're using the telehealth application. In West Michigan, they use Track a lot. They do these electronic, I call them like text messages back and forth. But make sure that you're noting what methodology you used for that communication too.
The last thing you really describe is really the last thing you do for a patient, and that's how you transfer them at the hospital or their final destination. Emily Baker, can you help us understand the best information possible to include in that EPCR for the transfer of care? I mean, you work in a hospital, you see these all the time. Help us understand what best to put in that PCR for that narrative about me transferring my patient to your personnel.
So it does not have to be complicated. Simply state that the patient was moved to the ER stretcher, how they were moved, and that report was given to person X or persons multiple. It is very important to document a name if you are able. I have very thankfully on neither side been involved in a situation where transfer of care was questioned, but I have worked in facilities that those questions have come up. And it is very important to be able to protect yourself and your patient by stating that you gave report to Megan RN or Dr. Sarah Smith or whatever the case may be. And it's also important to document that the patient was left in a safe situation, that the patient was on the ER stretcher, the bed was lowered, and the rails were up. You do not want to be potentially held responsible for a fall or injury to a patient that occurred after you have left their side because the bed was left in an unsafe position or something of that nature.
That makes sense. You guys are helping me clean up my narratives as we're learning this now. I'm going to add a few things. I thought I was pretty good at them, but looks like I'm going to add a few things. Now let's talk about a little bit more of a time-sensitive emergencies here. Now there's additional information required in an EPCR narrative of an EMS transport of a patient with a time-sensitive emergency. Those are things like a STEMI, a stroke, party 1 or party 2 traumas, sepsis, things that they need the information right away. Emily Berquist, help us understand this additional information that needs to be included in my narrative with a time-sensitive emergency.
Starting off with the specific assessments, you are putting the specific assessments maybe in a different section. Like, for example, the stroke scale. There is a specific place to put a stroke scale, but the description of what the issue is goes into the narrative. If they're having difficulty speaking and you're marking them down for verbal in the Cincinnati stroke scale, what is it that happened? Did they have expressive or receptive aphasia? Whatever the case may be, that has to be put into the narrative because the Cincinnati stroke scale specifically, actually most pre-hospital stroke scales, they're kind of these check boxes and they add up to something, but they don't give a really great picture. So be more specific in your narrative about what's going on. And that goes kind of across the board for all of our time-sensitive emergencies. What specific things did you find in the assessments? And then times, we've talked about this too. There are a whole bunch of different times. Most of them in time sensitives are related to onset and last known well. When was the last time that somebody was, as far as we know, 100% normal? Or if we can pinpoint a specific time exactly when this thing happened. And then if there's anything that has gone on that has caused them relief. So like they had it, it went away and it came back, right? There was a TIA and then it resolved and now it's back. All of those times are important. The transport decision information, this is a really interesting thing because this is something broadly in EMS we do a pretty poor job on. Not that we choose the wrong destination, we don't document well why we chose that destination. Everybody defaults to transported to the closest hospital per protocol. Well, in urban areas, a lot of the closest hospitals are trauma centers or stroke centers or STEMI centers or et cetera, fill in the blank. But the reason that you're going there, maybe note the fact that they also have the capabilities of doing these specialty interventions. Make sure you're picking the right reason for choosing that destination when you're documenting and noting it as such. So you might be going to the closest facility, but you should also note that it's level 1 trauma center. In Oakland County, you have a lot of facilities in a relatively small geographic area. But I mean, it does happen all over our state every day where many hospitals are getting passed to get patients to the most appropriate facility. And you could say closest appropriate because that's the appropriate facility. But if you're passing 3 to get there, you should be documenting why you're passing the other 3.
Got it. So if I'm going to say transport to the closest appropriate facility, it better be, and it better not be able to be provable that I bypassed another facility.
Right. Or you have to document why it was appropriate.
Right. With that time, I'm probably getting online medical direction involved to make that request.
Exactly.
Okay. What's next?
Ongoing assessments, for example, like 12 leads. This is something people have a tendency to take the 12 lead off of a patient once it's on. Don't do that. Just leave it on there. Put it on the patient. Leave it on there. Most of the monitors now are super smart and they will prompt you if there's a change in the 12 lead. Just for reference, they don't just pop out randomly. If the monitor is choosing to give you another 12 lead, you should really look at it because there's a reason for it. Stroke scale, if there's changes in the patient, checking and being more specific. Obviously, if the patient is changing or appears to be very sick, you need to make sure you're getting lots of vital signs. Anytime something is changing with a patient, yes, it will show up in your flow chart because you did another 12 lead or their blood pressure changed or whatever, but not everything can be caught every single time. So make sure you're describing what you're seeing as this relationship with the patient progresses with the time you're together. The last one is activation. So did you tell the trauma facility that you were bringing in a level 1 trauma? Not, they're probably going to be really mad at you. Make sure that you're notifying. And when did you notify? You might be notifying of a trauma when you're still on a scene. And that's okay. They like more time. They like to be ready. Same thing for STEMI is the second a STEMI shows up and it really looks like a STEMI and it talks like a STEMI and it acts like a STEMI, wherever you're going, you should be like, hey, guess what? We're bringing you this. Get ready. Do your activations. Note when you're doing the activations. Put it in your chart, and then we can keep track of how things are working.
Thank you. This quick commercial break is brought to you by our educational partners, American CME. AmericanCME.com is an online continuing education learning platform designed for EMS providers by EMS providers. Their mission is simple: create and host high-quality video-based EMS CE content with the aim of improving the quality of EMS care while drastically reducing or eliminating the cost associated with EMS training. American CME courses focus on the most current topics and science related to the EMS industry and are available in a format that makes them convenient to access and complete. Over the last year, the EMS On Air podcast has teamed up with American CME to host many of our episodes on AmericanCME.com. This means that EMS providers can earn EMS continuing education credits by completing an entire podcast episode, a brief post-course quiz, and a survey. To do this, visit AmericanCME.com, click on the courses link, then click on free courses. Scroll through the course list and look for the courses with the EMS On Air podcast logo. Currently, there are 22 different EMS On Air podcast episodes hosted by AmericanCME.com, including the episode you're listening to right now, that are approved for continuing education credits for EMS providers in Michigan. But don't worry, we're working on getting our episodes approved in all 50 states and CAPCE accredited. And we'll be releasing another batch of episodes sometime in May 2021. Get on over to AmericanCME.com and get you some credits. Think about it. Kicking back and engaged in an EMS On Air podcast episode and earning CEs. Come on, does it get any better than that for EMS Continuing Ed? Did I mention that you can access all of American CME's content for free? Yeah, free. And now back to the show. Now let's move on to a slightly different type of call. Sometimes I don't transport people. Sometimes they refuse to go to the hospital. Sometimes they don't really need to based on their medical complaint or who called them there for. There's various reasons, right? But what we do know is every time we have a patient refuse, we still got to do an EPCR. Can you walk us through that criteria and key information that should be included in every refusal of an EMS EPCR?
First and foremost, that the patient is competent and they have the capacity to refuse. Yes, everyone has a right to kind of decide what's going on for their own body, but you have to make sure that you are showing that that patient is capable of making that decision, because that is something that someone can lose because of all sorts of different medical conditions, behavioral health situations, etc. So make sure that you're documenting that this is a competent individual. Are they legally able to make the decision, or is there a guardian there that can make the decision for them? So some people will say, well, their durable power of attorney was there. Well, durable power of attorney is not the same as a guardian. So you need to make sure that if you're using a durable power of attorney, you're using it appropriately. And most EMS people are not trained very well for that. So make sure that you're verifying they can either make the decision or there's someone there to help them make the decision that's appropriate and legal. You need to make sure you document what you told them you thought was a good idea. What did you recommend them do? Did you say, please go to the hospital? This is really important and you're very, very sick? then you write down exactly what you said. And do not write down things that you did not say. So if you did not say to the patient, you should go to the hospital because you might die, that's the risks, which is the next part. If you didn't say that, don't write it down, because the patient might ask for that report someday. Then they're going to know that that's not what actually happened. So make sure that whatever you said is what gets documented. And then whatever risks that you explain to them. And sometimes there's not a lot of risk, and that's okay too. Just be clear that you're documenting all of those things appropriately. Then documenting that the patient understood that that was the risk. And sometimes that means that you need to talk to someone else about it. That means you might need to talk to medical control if the patient is not doing what you would like or making decisions that you don't think are appropriate. Make sure that you're finding someone else to go along the ride with you to make sure the patient understands what's happening, or the guardian, or whoever that particular person is. And then having the signatures that you need to have, as well as if you need to have the documenting who the medical control was that you had signed. We always get signatures in a different section, but we want to make sure that in the narrative, we're writing about who signed. The patient signed for themselves, or the guardian did, who the guardian was, or the relationship was, and then also talking about who the third-party witnesses were and what their relationship was to the patient. So it's a spouse, it's a parent, it's whoever. Make sure that that's described inside your narrative, so that signature box, which is mostly illegible, and the little bits that you can, there's like little things that you can check about that person, it doesn't really fully give a whole picture. So make sure you're describing that in the narrative. So you need to make sure that, I should say, who the medical control was. Yeah, documenting their name, when you talk to them, what they said. For example, now sometimes you're having like a actual video thing, and the doctor is maybe giving the Coming to Jesus lecture about how they should go to the hospital. You need to make sure that you're also documenting that Dr. Smith told the patient these things also. I told the patient, Dr. Smith told the patient at this time, so that all of those things are documented appropriately.
And then finalizing that by having somebody witness it. Now, I always have my EMS partner witness my refusals. And then when I write in the narrative, the patient or guardian or whoever signed for this patient the refusal as witnessed by, and then the name of my provider with me. And that kind of rounds out the EPCR narrative for refusal. But here's the thing about dead people. They don't refuse, but we don't transport them, right? Not to make that sound weird, but, lightening up the subject a little bit here. There's a lot of nuance to drafting an EPCR for a patient that you are pronouncing. Emily Berquist, walk us through what that is.
We're going to kind of talk about the two paths, right? Like if you do resuscitate a patient, you have to write almost a whole normal report, right? You're still documenting all of your dispatch information, all of your response information, all of your treatment information, all of that. The only part that you're leaving out, like if we use the DRAT methodology from earlier, you're just leaving out the transport part because you're not driving them anywhere. So the whole report, a pronouncement, is a super long report. It should be a super long report. What did you do? How long were you there? All of that. And then, okay, now we're talking about pronouncement. We need to make sure that we have all of our protocol requirements satisfied. The patient was in asystole and 3 leads. We've done all these things. We contacted medical control. It wasn't a crime scene, whatever the case may be, whatever the pieces of your puzzle are, those all have to go into the narrative because there's nowhere else to put it. There's just not anywhere else to put it in your report. So make sure that you're giving all of that information in there for your resuscitation patients. The next one being, if the patient is obviously dead, you don't have to have obviously all the treatment stuff because we're not doing anything, but you do still have to document that all of the, or what the protocol checkboxes were for an obvious death. I always use decapitation because it's not something we see very often, but there's no more obviously dead than decapitated. So clearly describe that. If it's a patient who hasn't been seen for a couple of days and there's specific things about the scene and about the body itself, you have to be descriptive about it. And it is not awesome, and some people don't like it.
We don't often have a lot of education in identifying states of decomposition to a human. And so the terminology used sometimes is conflated or confused amongst our providers. And so when people say dependent lividity, it's important that you know exactly what that looks like and when it can set in. So it's important to really do your due diligence that if you're going to say a patient is meeting criteria, to know exactly what that means and what it should look like.
Yeah, don't use words that you don't know. That's kind of a universal a universal thing. And if you don't know dependent lividity and you don't know rigor mortis, then you can describe what they are. Like if you don't know those words, you can say, there's blood pooling to the posterior side of the patient and the patient is rigid throughout his whole body, unable to open the patient's mouth, etc. Those are all things that you can describe even if you don't know those vocabulary words. So there's other special circumstances that you might have to document. Does the patient have a DNR? Is there family there? There's a hospice on scene. All of that matters. It's important to document that those things are or are not present.
One way I always describe that is that end of life plan. Do they have one, and what is it?
I think it's very important to note that it is not uncommon for people to express their wishes to their family without putting them in writing on a legal document. So, a couple that has been married for 30 years, the wife may be very aware that her husband's condition is deteriorating and he does not want heroic measures. However, they haven't gotten that in writing yet. A lot of EMS providers are under the impression that in that case, you have to do a full protocol, 30-minute ACLS resuscitation while the wife cries in a corner. And that is not true. Begin your resuscitation efforts and call medical control. Physicians are very well educated in these situations. They are very aware of how frequently they happen, and they do want to respect the wishes of the patient and family. So utilize those resources to allow you to deviate from the protocol when you're in a position where that is the most respectful to the family and the patient.
And I really think that brings it both together, right? You're starting the resuscitative process, but you're also communicating at the same time, peeling one person off to maybe take that family member. Hey, let's go talk to the doctor. Let's figure this out right now. And as soon as we're all on the same page, we can make a decision right away. And I think that's a lot easier to digest for somebody witnessing their loved one go through something that they know they don't want to. And it also relinquishes the EMS provider from having to make this tough decision that they don't need to make. Now, while you got them on the phone with medical control, what else is important?
Time of death is something that the physician is going to get, what the physician's name is, and the spelling of the physician's name. And what hospital, too, you have to think about it from the perspective of this is not a transport, so you're not going to have a destination facility in your other portions of your report. So if you contact Joe Smith's hospital, make sure that you're noting that you spoke with, especially if it's a common name, this physician at this hospital at this time. They pronounced death at this time. It's all important. That entire conversation is important.
And it's also important that you have a form in a lot of ePCR platforms that allow you to document the whole cardiac arrest, including the doctor's name and the time of death in there. They'll have a separate section. But again, you still need to list it there and describe it in the narrative. Now, one of the things, especially in Oakland County, and the laws are different all over the United States. In Oakland County, Michigan, law enforcement or a medical examiner will get involved in the case and take possession of the body. Now, it's very important that we adhere to putting information in about this. Why?
Well, and I can't speak to Oakland County specifically. And that's really interesting about Michigan, is Michigan doesn't have a statewide medical examiner. Every county is different. And I'm not kidding. Every county in the state of Michigan is different about how this is particularly handled. But for example, if you are leaving a body somewhere and you have not given that body to someone else or made a plan, right? It's a hospice patient. Okay, hospice patient, we've documented that. It's not a suspicious death. We know we can leave the body. That's okay. But a lot of other people, you should be documenting that somebody was there in case something happens after you leave. So whoever the law enforcement agency is, are they the one who contacts this medical examiner? Are you the one who does? And all of that needs to be documented in case something gets kind of dropped along the way.
Yeah, it's very clear in our protocols that the custody of the body has to be relinquished to the appropriate person. So please look at your protocols to kind of go through that. And then what actually happens during the event, document it. And a lot of times where I work, law enforcement arrived on scene, transfer of care to law enforcement officer number, whatever it is. And a lot of times that satisfies it, because then they're going to have a report that follows through with their paperwork, essentially, with the chain of custody of that body through the medical examiner. And finally, to round out this discussion on EPCRs for that pronouncement on scene, why is it important to document how the patient was left at termination of care?
Well, one, if you left any equipment in place, which you should be, honestly, you should be leaving it there. Obviously, that should be the rule. There are exceptions, but
Can you
generally speaking,
the equipment specifically? You're not talking about leaving my life back, but you are
no.
talking about leaving the lead.
Things once things are inside the patient's body, you leave them inside the patient's body. So if you put in an ET tube, if you put in a supraglottic airway, if you put in an IV, etc., those things stay until there has been some sort of a decision that EMS does not make about what's going to happen next with the body. So if you have been resuscitating a patient, we're going to presume it's not a hospice patient, right? So if you're doing that, someone else needs to decide at what point in time that stuff is taken out of the body. That stuff stays there. You document it as such, what position the patient was in, etc. In case there's a question after the fact, were you doing CPR on a patient sitting up? Those things need to be documented. If that was happening, why was it happening that way, etc. So it's important to make sure that all of those things are in there for clarity for later, and it can be a lot later.
This is also an excellent place to include any measures that you took for the comfort of family or bystanders on scene. If a sheet or blanket was placed over the patient and you cleaned up around them, things like that are important to document as well, because at the end of the day, there is still a very human factor to everything that we are doing. And you're doing things for the sake of compassion and for the sake of the family who is an extension of your patient. And that should be documented as well.
Very good. I totally agree. Emily and Emily, this rounds out our 4-part discussion on EMS documentation. And really today we got into the last bit of it, which is telling the story in a narrative. Any final thoughts today?
I think that it's just most important for people to get to a level of comfort with their documentation. I don't want people to feel burdened or too scared about their documentation. It's really, really important, and you should understand the gravity of why it's important. But you should also consider it kind of, I guess, something that is a great part of your job. Your clear communication can really help a patient down the road. So make sure that you're doing it in the best way that you possibly can. And if you need to practice, and have other people look at it. Ask your quality improvement supervisor, ask your partner, ask your trainee to look at your documentation so that you're getting more perspectives, because we're all learning every single day. So make sure that you're doing it as best as you can and doing your own kind of continuous improvement on it.
The biggest takeaway that I would want everyone to have from this education is that EPCRs are medical and legal records, and that they need to be written in a professional manner. Being thorough and organized and documenting accurately is incredibly important to your patient's care and to yourself in the long term. This is your security blanket, and I want you to all to hold on to it tight.
That is all for the show today, everyone. Thank you for listening. Thank you to all of our guests for coming on the show and spreading your knowledge. If you want to get a hold of any of today's guests, you can find their contact information in the episode description. Also, I'd like to take a quick moment to recognize the other EMS providers that were directly involved in the development of the content presented in this episode. Thank you to Allison Bellitti, Luke Bowen, Justin Allen, Yehuda Kranzer, Chris Watts, Matt Prang, and Dan Miller for your time and participation in the development of today's content. Your time is truly appreciated. Please keep emailing your questions, comments, feedback, and episode ideas to the EMS On Air podcast team by email at qi@ocmca.org. Also, check out our website, emsonair.com, for the latest information, podcast episodes, and other details. Follow us on Instagram at EMS On Air. And please, whatever podcast platform you use, subscribe to the podcast and leave us a rating and a review, because it really helps us to grow this podcast. Thank you for listening to the EMS On Air podcast. Stay safe and have a great day.